So when you identify PIK3CA mutation, how does that change your treatment or your thoughts?
Yeah, so I think if we're identifying it upfront in the first line, then I'm really sticking to that criteria for Manavo 120 to see if it was within or during adjuvant or within a year of finishing adjuvant endocrine therapy. But that changes now my frontline management is, and then if I found it before and I see it again, then that definitely influences my selection of second-line therapy.
Right.
And so they're paying attention to what specific alteration it is, realizing that I like to look at the variant allele fraction that's there and see, do I think it's the dominant clone in ctDNA? But I realize sometimes we overinterpret what we actually know when we make these decisions, but heavily influences the second-line treatment option.
Yeah, I agree. I mean, there's a rare subset that a novel is appropriate for, right? That's a triplet. It's more toxic, but for the right patient, certainly the comparator on that trial did very, very poorly, right? So I do agree. I think I use it, if you have someone where you're thinking about a PIK3CA inhibitor as their second line, that's your time to potentially optimize their metabolic disease, right? Their diabetes or pre-diabetes. Make sure they do have a PCP or an endocrinologist who's going to be ready to help you when you get there, right?
Absolutely.
So I think it's just helpful for planning. And I think patients find it reassuring if you can tell them, yeah, we've got a great second line option for you when you need it.
I very much echo those sentiments. It's like nice to show, whenever we get the test results back, you can say, yep, we already know, planning ahead, we already know what we're thinking about doing. Yeah.
Great. Okay, so let's talk a little bit about TrueCap and PIK3CA altered disease. So when you think, we talked a little bit about when to treat patients with PIK3CA alteration, but let's talk about that second line setting. What kind of stands out for you? Which are the patients you think might benefit the most?
So So I feel like right now my struggle is we have so many different choices and options that are there. And if we look at some of the more recent phase 3 data, it's kind of trying to figure out what to use when. But if I look at the currently approved options that are there, our practice shifted pretty quickly towards Capivasertib once it got approved, mostly because of our the toxicity profile. So I think like right now, I'm making most of the decisions in the second line setting based on my perception of the toxicity profile rather than efficacy, because we have no head-to-head data yet. But it's coming soon.
Exactly. Exciting. It's going to be an interesting ASCO. So
what did you end up doing, or how are you viewing?
So I was participated in lots of the alpelisib trials, so I had a lot of experience with that drug, and trying to convince a lot of community colleagues to give it a try, and it really did see the struggles, particularly in New Mexico. We have a large Hispanic population, a large underserved population. Diabetes is very frequent, and so there was real struggles with that. So I agree with you. I think that one of the advantages of Capivasertib certainly was the lower rate of hyperglycemia. And so I think also our practice almost universally has switched to using Capivasertib for PIK3CA altered metastatic breast cancer.